what are the downstream side effects when you have people on weight loss medication or GLP-1s?
We're not asking for it cheaper. We're asking for your best price. If you're going to sell it to another country for $100, we want $100.
Yeah. Right now, every other day, I see a new study on how GLP-1s lower cancer risk. GLP-1 lowering cardiac events, lowering congestive heart failure, lowering dementia.
If you're a listener now and you have no idea what a GLP-1 is,
I'm gonna make it very simple, right? GLP-1 is a medication that works on your brain to make you less hungry, works on your stomach to make your stomach less efficient.
So we've got the most sedentary, the heaviest population on history, with the most access to high caloric food and money to buy it.
Opioid murder. A lot of the unintentional overdoses were kids who they were opioid naive. They just found a pill, they took it, and they dropped dead.
Terrible.
Yeah.
I don't know that there's a benefit on the THC side yet.
If you're in a long-term care setting, you may be there for 6 months, you may be there for 3 years. How do they think about addiction, and do they even consider toxicology?
I took the tirzepatide and I lost weight instantly. So much weight that it was more like muscle.
If you were the architect and the author of DSM-5, would you classify obesity as an addiction?
Welcome to Our Purpose Podcast, a podcast where stories from skilled nursing and long-term care come to life. I'm your co-host, Kip Kruger, a voice shaped by industry experience and a belief that everyone's story has a purpose and it's worth telling. We got a wonderful episode today. I'm excited to be here. How are we doing, fellas?
Good, man.
Doing great.
Yeah.
Good.
Yeah,
Looking forward to it.
I'm excited you're here.
Yes.
This is going to be a good one. We're going to talk a lot about purpose, GLP-1s. Woo, that's hot. It's going to be a good one today. Dr. Vargas is sitting across from us. Chris Light, give us an intro, brother.
Norberto Vargas joining us today, who's board certified in physiatry, pain, addiction, and obesity, practicing primarily post-acute,
100% post-acute care.
in the DFW market. Mm-hmm. So we're just going to jump right in. You and I had spent some time chatting before. We're going to hit all of those topics today, but I really want to start with weight loss. Specifically, I want to talk about a couple different things around weight loss, your experience with it. I know you're educating folks on it now, but I also want to get into just access and then kind of what are the downstream side effects when you have people on weight loss medication or GLP-1s. And so however you want to start with that.
Yeah, I think it's a complicated topic, right? Depending on the setting that we're discussing the topic right now. I was talking to Kip about GLP-1s in post-acute care, right? Okay. It's fairly new. There's a lot of facilities that are embracing the use of this medication. And the challenge in post-acute care is that, our prior vision is that if you have a patient that is losing weight,
yep.
I mean, you can potentially get an FTAC just from it, right? Dehydration, weight loss, 5% weight loss. And up to about 48% of patients who are admitted to skilled nursing facilities, they're actively losing weight, right? Now you potentially add to it a medication like a GLP-1, right? Whether it's Ozempic or Mounjaro, which are indicated for management of diabetes, type 2 diabetes. And potentially we can really put that patient in a bad situation where not only they're losing weight, but they're losing muscle mass. And the implications of sarcopenia in the case of skilled nursing facilities are huge, right? Because you have a patient there that has a skill need, they just broke a hip, they have a compression fracture, they maybe had an amputation, and because of that combination of GLP-1s and diabetes, they're losing weight, they're losing muscle, and you're not having progress with therapy, right? Which is our main thing. I'm going to flip the coin, right? And in post-acute care, because of obesity, right, we see patients who are either class 1, class 2, class 3 obesity, class 3 being BMI 40 and above, where you may need special beds, right? You may need special equipment. Yep. And that's the type of patient who can potentially be a game changer situation where you're addressing a skill need and you're also addressing weight loss, which is a big one. You flip the coin to the another setting, right? Which I think you're asking about the outpatient setting. And on the outpatient setting, weight loss went through a massive transformation, right? When we first had semaglutide and Mounjaro, tirzepatide, there was a real shortage of that medication, massive shortage, right? Especially because it was only indicated for diabetes and eventually had an indication for weight loss. And with that, it created a massive market for compounding medications that are safe, effective, right? Legal to prescribe. And from a compound, it created a literal dichotomy of care where if I get semaglutide through a compounding pharmacy, I may be paying $300 a month versus $1,200 if you use Wegovy, right? Or if you use tirzepatide.
Huge difference.
Massive difference, right? And with that, it created a battle between Novo Nordisk, Eli Lilly, where they were trying to fight the compounding aspect of it.
Yeah.
So as a provider, it was a real revolution to be able to serve the patient, give them a medication that works, that is safe, that we know that it's going to be transformational for the health, and at a cheaper price. With that came a legal battle, right? Came a legal battle where you saw a lot of companies suing compounding pharmacies, and to a degree that affected the availability of the medication.
Yep.
Has that stood? I know like the big one was, I think Eli sued or sent a cease and desist to Empower, which is like one of the largest ones.
I
They're
think
based
we're
here in
still
Houston.
So those lawsuits are ongoing.
There's a lot of issues that are happening because now what you see is that Eli Lilly, Novo Nordisk are giving a massive discount on their medications.
Yeah, so I was going to mention this. Okay, you start off, I want to rewind just to something you said a minute ago. So if a patient loses more than 5% of their body weight, you could get a tag, right? An F tag. Is that even go for obesity? Or is that a ruling that exists within the facility? Or
as a facility, you have to take multiple things into account. 5% weight loss, it's a standard number, right? But you have to take it into the context of the patient.
If you're morbidly obese and you lose 5%, we would consider that good. I'm saying, is that something where they look at just as a general rule, 5%? Or do you have to worry about it in obesity?
So you worry about multiple factors, right? Just like obesity is multifactorial. 5% is just a number, right? And typically that 5% number is something that we see on patients with dementia, Parkinson's, something that we're really monitoring them, because once they start in this weight loss cascade, very difficult to pull them out of there, right?
Got it.
But that's more on the long-term side. On your side, there's a benefit for the patient to lose weight. The challenge is that a lot of the weight that can happen, it's sarcopenic weight. You are losing muscle, right? And that's not a real benefit for the patient. We talk about this term called sarcopenic obesity, where you may have a patient who has a BMI about 40. They lose a little bit of weight, but it's mostly muscle weight. And that creates a real impact in regard to function, right? As a physiatrist, whether I'm in post-acute care, whether I'm an outpatient, we're really pushing function, right? So we don't want to do harm to that patient.
I want to bring us back to something you said just before there. So my understanding is that it was in the last 2 weeks. So we're sitting here filming in beginning of, I guess we're kind of mid-January. So just to frame this, because this doesn't drop the next day. But my understanding, a few weeks ago, President Trump sent a letter to the 16 largest pharmaceutical companies in the world and essentially demanded that we have the same price provision. So to give some context here, as you mentioned, Mounjaro was $1,200 in the United States. They were selling it in Europe. Same company was selling it in Europe for $140. So as of now, my understanding, Medicare is that now we can get it for $140. So our government's buying. Have you seen the prices actually come down? Is the accessibility of the brand names come down as it's being told to the public in the media?
So I haven't seen that yet consistently, right? What I have seen, it's a lot of pharmaceutical companies, Eli Lilly, Novo Nordisk, having their own programs to lower the price, right, of the brand name medication.
Okay, so that's probably you are seeing it then.
That's what I'm saying.
So my understanding is that they've been kind of forced into complying to bring the price down, essentially saying the United States is no longer going to pay one price when you're selling it to other countries at a different price. And we're not asking for it cheaper. We're asking for your best price. If you're going to sell it to another country for $100, we want $100.
Yeah.
If you're going to sell it to another country for $60, we want it for $60. But my understanding is that is not necessarily legislation that was passed, and they're trying to back it up with legislation, but, man moves fast. So I'm just curious what you're seeing on the field.
Well, you think about, I remember going back maybe 4 years ago, right? And we discussed, I saw an article about numbers, right? And what will be the cost of prescribing GLP-1s to Medicare recipients for the government, right? And it's the cost. It's closer to trillions of dollars, right? If you were to cover everyone that needs it, and I don't know that we're in that position. And at that time, I believe that we were talking about prices like $1,200 a month, right? So if there's a significant cut in price, I think it will make it that much affordable, and we can really see a benefit not only from an obesity standpoint, but right now, every other day, I see a new study on how GLP-1s lower cancer risk, GLP-1 lowering cardiac events, right? There's actually an indication for semaglutide for cardiac events, lowering congestive heart failure, lowering dementia. I mean, it's insane.
Do you think that's from the weight loss, or is that from the actual GLP-1? And also, I would like for your perspective on indications. So as of current, are GLP-1s strictly indicated for diabetes type 2, or is there an actual obesity indication?
There's now an indication for diabetes type 2, right? That we know about that indication. There's indication for obesity.
Okay.
And there's indication for cardiac events, right? So, so that's there. And, even on the addiction field, right? In the addiction field, we found that patients who are treated with GLP-1s that are able to go into remission, right? From whether alcohol or whether opioid abuse. So the story of GLP-1s, it's
still writing
it's
itself.
an ongoing story,
Yeah.
right? It's happening. We don't know, to answer your question about what specifically is it that it's happening that makes such a dramatic reversal of disease. We do know that when you have a patient that is in poor metabolic health, right?
Yeah.
Insulin resistance, high lipids. You have a patient that potentially fatty liver, right? That weight loss alone will make a massive transformation, but the science of GLP-1 is still being written.
Yeah,
and I think that there's more to that.
I've got two questions kind of backing up to like the listeners. If you're a listener now and you have no idea what a GLP-1 is, can you give me an example or a definition of exactly what a GLP-1 is?
I'm going to make it very simple, right? GLP-1 is a medication that works on your brain to make you less hungry, works on your stomach to make your stomach less efficient. Basically, it causes slowing of the stomach motility, which makes you fuller, and it works on your pancreas not only to create more insulin, right, but also to create better insulin. Right, that's my best definition of a GLP-1.
Why are we seeing it now? Now it's GLP-1s are huge, and I'll talk a little bit about GLP-1s here in a second. But why are we seeing just an absolute chaos of information and GLP-1s flooding the market? Why now?
I think ever since the discovery of GLP and their mechanism and how transformational the medication was, we keep finding new indications, right? We keep finding new indications. They work. They are really good about helping you lose weight. The challenge is what happens when you stop taking it, right? Yeah. And we do see that at about 2 years that there's a significant rebound of weight gain. Now, you talk about bariatric surgery. Bariatric surgery 20, 30 years ago was the all-in thing, right? I remember that we will see bariatric surgeons having seminars, right? with massive amount of patients they're looking for help. And now we're at a point that we get same results as having either gastric sleeve or SATI or the old gastric bypass in regards to weight loss. Typically, I want to take you back to the days of using metformin or phentermine or all the old drugs that we use. And if we saw 5% weight loss, that was significant, right? We consider that to be significant. GLP-1s, on average, you lose about 10 to 15% body weight, right? Which is closer to gastric sleeve. Gastric sleeve, you typically lose about 15 to 20%. Mounjaro, tirzepatide, will get you there too, right? So it's a very effective medication. It's another option on top of bariatric surgery. And we see a lot of GLP-1 use just because there's a need, right? Yeah. If there's a need and there's a perceived value creation for whoever's taking it, it's going to be used.
I think I'd like to comment and answer that question from an economic standpoint. Yeah. So let's back up to the point where the country has never been richer and we've never had more access. So let's talk about just in general, people, as bad as the media makes the world look today, in America, we're a very rich country. Nobody should be starving here. You have access. In fact, if you actually look at people on Medicaid and on food stamps, they're the heaviest population. So the people who are given the money actually have more caloric intake, right? There is a Chick-fil-A on every corner. There's the opportunity to be sedentary, sit there and scroll through your phone, look at TikTok and whatnot, and people are doing that. So we've got the most sedentary, the heaviest population on history, with the most access to high caloric food and money to buy it. So there's your problem. Yeah. Fast forward to now that we have GLP-1s, you have an alignment. You have a pharmaceutical company who's looking at this giant problem saying, I've got a drug that I can sell and make this. And go look at their profit margins at these companies. Incredible. Massive profits. You also have insurance alignment for the first time ever. To your point, if you can bring down someone's weight, you have less cardiac events, diabetic events, cancers. I mean, when you start to look at metabolic disease and what it does, it touches everything. Mm-hmm. Every disease state is improved by this. So you have insurance companies saying, I'll pay for it. You have pharmaceutical companies saying, I'll give it. And you have a giant problem that isn't going to go away. It's the perfect storm.
Are there any negative side effects that we know now? Long-term side effects?
We do. And
because I have to. There's a personal reason why I asked this.
I'm afraid to ask why. You're asking this.
So I took tirzepatide.
Okay.
Why are you laughing,
Chris? Is this a HIPAA violation?
No, we're good. Everything goes on the Our Purpose podcast.
Okay. All right.
Kip did not lose 15%.
Yeah.
He was trying to get abs for a beach vacation.
Listen, we all have a different reason, right? We all have a different reason to use it.
I took tirzepatide. Right? It was my wife's anniversary. It was 2 months. I wanted to look good.
So let me ask you a question. Yeah. How many units did you take?
Oh, I took one shot a week.
Okay.
5?
So 5 milligrams.
5 milligrams.
Okay.
So I took here. Let me digress. The reason that I did it, I wanted to. I feel
we're not judging you, right?
I'm a little bit skinny.
Oh, you are.
I say that I'm skinny fat.
Judging.
Yeah, I'm skinny fat, right? So I feel like I'm skinny fat. I wanted to look a little better, right? So my wife will appreciate that. And then next, like I wanted to control my sugars. And I wanted I believe that it was the education that I was provided that the visceral fat, it shreds the visceral fat around your organs. So I was like, oh, those 3 things are really, really good for you. I took the tirzepatide and I lost weight instantly. So much weight that it was more like muscle. I don't have very much muscle, but I lost the muscle that I did have. And I was like, whoo, I got to get off this. So the reason I asked is like long-term side effects, is that something that we should be worried about? Like, should I have not taken it? Like, help me, doc.
You're not going to grow horns, right? That's not going to happen here, right? Or grow a tail.
Okay.
But they are potentially short-term issues and long-term issues.
Okay.
Right? From a short-term issue standpoint, what we saw, it was very peculiar because we saw the same side effects that patients who underwent bariatric surgery had: hair loss, dramatic muscle loss, low testosterone, hormonal problems.
That tracks.
Yeah. I have no hair. My hair's gone.
But that was at the beginning, right? And when you think about it, when you take a GLP-1, one of the things that we always talk to patients is, let's make sure that you don't lose more than 1 pound or 2 pounds a week, right? Let's make sure that we keep it simple, make sure that we go up on your protein intake, and that we get you into an exercise program.
That was probably the hardest part for me. I felt like I could never eat enough protein because it did not make me hungry, but I knew that I needed to eat protein, but I wasn't hungry. It was so difficult to eat enough protein while I was on it.
It is, right? And you think about a bariatric patient, right? They don't have an option, right?
Yeah.
They have a stomach that is this size, they have a bypass, they have a malnutrition disorder that is ongoing, and that's the type of patient that we had to supplement with vitamins. Sometimes we use vitamin patches, injections, IVs. But in the case of GLP-1s, there are occasions where I had to tell a patient, listen, we need to back off a little bit because you are losing too much weight. Okay. Now, one thing that we've seen is that we've seen a condition called optic neuritis, basically sudden onset of complete visual loss.
Wow.
Which it's non-dependent on blood flow. So there's a condition called ischemic optic neuritis. It's fairly common on patients who have rheumatological disorders, and we've seen an increase in that condition on patients taking GLP-1s. Just like we've seen patients who develop this peristalsis disorder where they really have a hard time tolerating meals, right? They, to the point that they vomit, they may need a peg tube.
This is just from lack of motility.
Lack of motility.
So just put your stomach in a paralysis?
Paralysis.
Yeah.
Wow. Right.
So we've had in our I would say, at least people I know of, I don't want to necessarily say the friend group, but people we know of, we've seen an intussusception with a surgery. We've seen optic neuritis.
Small bowel obstructions. Those are things that can happen.
Right.
But in the context of potential complications, right? You had to weigh the massive benefits that I'm getting from the medication, right? So look at you now. You look much better. You're a 10 out of 10. Your visceral fat is 10% less, right?
He used to weigh more than
my opinion.
He used to weigh more than my 11-year-old daughter. So
I
you look
think he
great
looks
now.
great.
Yeah.
He said 10 out of 10.
Man, we're going to have you on every week. Thanks, Dr.
We're
Vargas.
happy to.
So question, you know what I haven't seen is anyone that's actually heavy have these issues. Like I keep seeing the issues come from the folks who are just doing it to look great. They look good and they want to look better. Are you seeing, I'm really curious in your practice, are you seeing people who really need the medication? Not to say you didn't.
Yeah. So I had to kind of split that into two things, right? My current practice is 100% post-acute care, right? My prior practice was, outpatient pain, addiction, and obesity. And when you think about the beginning of GLP-1s, and you think about OMA, right, the Obesity Medical Association, which is, what certified physicians board gives a recommendation to the Texas Medical Board in regards to doing the right thing. There are certain limits in regards to BMIs, in who qualifies for what, right? So anybody under 25, right, BMI. We're pushing it, right? Yeah. Maybe there's a benefit on the cardiovascular side. Maybe there's a benefit different. But, technically, based on, obesity guidelines and recommendations, anyone under 25 BMI, there's really not much benefit, right? To do a GLP-1. So that's something that you have to take into.
So your suggestion to them is just like get in the gym. Don't take a GLP-1 if you're under 25. Get in the gym.
Do the work.
Do the work.
I think that, it depends, right? Because if you're of Asian descent, right, potentially 25 BMI, it's considered pre-obesity, right? Yeah. So you have to take also cultural issues in regards to that.
What are we've talked a lot about some things that could go wrong and this and that. In a specific skilled nursing facility, who's your ideal candidate and where do you see the most success of facilities actually utilizing that?
The
medication?
Ideal candidate will be a patient who's in long-term care, right? Who has uncontrolled type 2 diabetes and their class 1, class 2, or class 3 obesity. That will be the the typical patient that will benefit the most. And if you add to that patient a degree of physical therapy, you work with the dietitian team to make sure that they're getting, 1.4 kilograms of 1.4 grams of protein per kilogram of ideal body mass, then that's a patient that will be do great. You get a patient that gets transferred from the hospital to the skilled nursing facility. In the hospital, they're doing sliding scale, they may be doing insulin, they stop all the medications. Now they go to skill and you put them on a GLP-1. That's a hard sell.
Sure.
Right? That's a hard sell just because, one, in skilled nursing facilities, we try not to be as aggressive managing blood sugars, right? Sometimes we even skip sliding scale, right, in that population. But also, it's a patient that is likely already catabolic, right? They're losing body mass, they're losing weight, they're taking a bunch of antibiotics, they're taking pain medications, they're constipated from pain medications. So now they're not eating. Now you are at GLP-1, yes, their blood sugars are better, but they're losing muscle, right? They're losing muscle, and at the end, it's going to be very hard to regain that.
How does a facility avoid F-tags while using GLP-1s?
I think that there has to be a clear communication between the medical director, right, the dietitian team, and nursing, right? Someone like a CNA, right, that is documenting the patient intake. That's something that you really have to pay attention to because you can get an F-tag not only because of the significant weight loss, but also dehydration, right? Nursing homes are really dry places, right? We want to be sure that humidity is controlled. And, our elder population, they're not great about keeping up with fluids. So it can be a really bad combination.
Yeah. I'd like to just move this along. So you have, I believe, 4 specializations, addiction medicine, pain, obesity. Don't remember the 4th.
Physiatry.
The last one is physiatry.
Physiatry,
PM&R.
of course. I'd love you to just blend all these together because it could sound like those are 4 different things, but they overlap dramatically. And I would even argue that for most people, and I'd love to hear your perspective, that obesity is actually an addiction issue. And I don't know if we can touch on that, but
we'll talk about that. We'll talk about, and I'm even going to talk about DSM-5, right, which is basically the Bible in regards to psychiatric disorder. So I want to start first with PM&R, right? Physical medicine and rehab. And, our specialty, what we do is that we are all in regards to function, right? 20 years ago when I did my residency at Baylor, Dallas, I remember the first year we saw knee replacements, single knee replacements going to rehab. And they did great, of course, right? They spent 10 to 14 days in rehab. And by the time they left rehab, they were walking up and down stairs, right? By 2004, it took 4 years to go from knee replacements to now we're taking care of post-transplant patients, post-ICU critical illness myopathy patients, post-tracheostomies, and what they call complex medical patients, right? And that 4-year span that I saw at Baylor is what we see now in post-acute care, right? Post-acute care, it's undergoing a massive transformation in regards to patient care, what's required, what needs to happen, and what needs to happen in the future, right? And you take into account someone like you guys, right? Principal Labs. And I want to take you back to myself 15 years ago, working at a nursing home. We used to have something called charts.
Yeah.
You seen that?
Yeah.
Right?
Oh, yeah.
Prior to EMR.
Right.
And I found myself saying, okay, let me order a CBC, let me order a CMP, let me order a UA. I will have a chart. I will have to write an order. I will have to flip the page. Then I will have to give that chart to someone to get an order.
Yep.
That order will get done within a day or two, right? And I forgot to order an x-ray, right? So I did an x-ray too. So it will literally take 3 to 4 days to get the results back, right? And we talk about HIPAA, we talk about all this stuff in nursing homes, and there was usually a pile of results right here that I will go one by one,
See your results.
trying to find the UA.
Yep.
Right. So when you talk about what you guys done, right, in regard to value creation, leveraging technology, leveraging people, right, and the ability to get a result within 8 hours.
Yeah. Game changer.
That's insane, right? Yeah. So when you take that same model and you take a physiatrist like myself who has a board certification in pain management and a board certificate in addiction, years ago, I found myself in a place where I had to leave a practice. I had a significant disagreement with my prior practice back in 2012. And that's how post-acute care came into my life, right? Mm-hmm. And when I went to post-acute care, from a physiatrist standpoint, we saw that there was a massive need to guide that very complicated patient, get him to therapy, see what obstacles are there, and make sure that they either go home or they go long-term. But at the same time, we found out that there's a massive disconnect in regard to what the facility needs, what the DEA requires, and what's available, right? So now you get little grandma who just had a knee replacement or a hip replacement, and they get discharged on a Friday night to the skilled nursing facility. Grandma took Dilaudid 2 milligrams in the hospital.
Yep.
It worked great. IV, right? Pump. And by the time they go to the nursing home, now we're going to try to manage that patient with maybe tramadol from the
cold turkey.
Or cold turkey.
See it all the time.
Right?
Yep.
And you add to that there are pharmacies that don't work on weekends. Right? So years ago, I saw that need, and I figured out that if I'm able to solve that problem, right? If I'm able to onboard grandma to the facility, make sure that the pain medication is there, make sure that my team follows them from a rehab standpoint to see if there are any obstacles, right? Grandma passing out because she's over-medicated. Maybe she's constipated. Maybe we're using the wrong medication for pain or anything. Then I found that to be almost a similar level of value creation as you guys have done on the lab work side.
Got it.
So when you mix PM&R, when you mix pain, that's a great combination, right? Just because we're able to make sure that grandma has the pain medication at the facility. And when you add to that we are going through an opioid epidemic, right? And the opioid epidemic last year killed about 80,000 people, right? Which is a win. I want to make sure it's a win.
It's wild.
Because at the peak of the opioid epidemic, which was in 2022, we were losing about 120,000 people.
I just saw that fentanyl deaths have fallen off a cliff.
54%.
Why is that?
Closed border.
Number one.
It's part of it. Awareness, education is part of it.
Well, we've been educated for maybe 5 years, right?
The availability of Narcan?
Narcan 3, right? And, don't want to get into politics, right?
Sure.
But I had to, right? I had to. And border is a big deal,
For
right?
sure.
That really helped. President Biden, he opened up the use of Suboxone, and he eliminated what we call the ex-DEA waiver number.
Yeah, that was a big deal.
So any provider can prescribe Suboxone. Mm-hmm. Was really helpful to do that. And what I saw is that now there's a big group of patients who may be on Suboxone, who may be on methadone, that they have the same right to have a broken hip as you and I are, right? They get a broken hip, where do they go, right?
Yep.
They go to skill, right? And if we're able to help facilities to do that, then we'll be busy. So
I've got a question about the X license. So I had an X license, and the first year I was able to prescribe 20 Suboxone.
What year is that, if you don't mind asking?
Gonna age me now.
I'm sorry.
2011.
Okay.
And I could prescribe Suboxone to 20 patients.
Right.
And then the next year they let me do 40.
Right.
And I think I got up to 80.
So,
but why would you limit my ability to prescribe a life-saving drug?
So I'm going to tell you a personal history of how I ended up getting into addiction, right? And it involves Howard Stern. Anybody know Howard Stern?
Oh, yeah.
Right?
Yeah.
Howard Stern. So
We had him on the podcast last week.
that would be a great guest, right? If you have it here. So I used to be don't judge me too late, right? Howard Stern, and he had this sidekick, right? Called Artie Lang, right? And Artie, great comedian, right? He was a great comedian. Artie, one time he fell asleep in the show and he passed out and he didn't show up and all this stuff. And they were talking about this pill called Suboxone, right? And I'm listening to it. What is that, right? And at that time, you had something called the DATA, Data 2000, right? And that was an act of Congress to allow prescribers to get a DEA waiver, right? Mm-hmm. So typically, first year, right, as a prescriber who went through the course, and at that time, you were an MP?
NP.
A practice MP. And for MPs, they typically require a 24-hour CME course.
Something like that.
Yeah. Myself, I did 12. Once I did the 12, they allowed me to do 25 patients for 1 year, right? Not only they allowed me to do 25 patients, but I had to have separate files for my 25 patients, separate from my regular files. And I was receiving DEA visits every 6 months or so.
And you had to keep the files in a different place. I remember this very well.
God forbid that those files are mixed. Right? And imagine you're a practicing pain doctor. You have a busy clinic because you do a good job.
Yep.
And all of a sudden, Agent Smith and Agent McKenzie show up to do an inspection of your clinic. So that first year was 25, right? Mm-hmm. Then you needed to apply for a second waiver. Second year, they only allow you to treat 100 for us, right?
Yeah.
Then after that second year, then you had to apply for another waiver, and your max was 250 patients.
Mm-hmm.
Wow.
Unless if you were board-certified addiction, right? So once you became board-certified addiction, then you open up.
And I think let's even back up further. So Suboxone, for those that don't know, this is a combination drug of buprenorphine and naloxone.
Correct.
Right. So naloxone can be used as a life-saving drug, but in this form, it's more of just for addiction. But it's also really good pain medication for those that have had addiction. And to limit the ability, you know what? In the DEA would come by and check your charts.
Right.
You know what? We never had a DEA come by and ever do is check a OxyContin, morphine user, fentanyl user. No, just this drug.
Right.
Blows my mind to this day that the scrutiny that was placed upon a drug that I would say was quite useful and quite safe, and we're limited in using it. And maybe that's the lobby. I'm definitely not. I don't believe in. There's this evil plan out there, but at some rate, you sit there and go, we do know today that OxyContin was very influential in Congress. They pushed down the pain protocols. So it is interesting to think that.
So, man, we can get deep on this,
Let's
right?
go.
So I have to be careful. So let's talk about Purdue Pharmaceuticals.
Yeah.
Right? Sackler Brothers, right? Mm-hmm. And I want to take you back to 2003 or 4, where if you go back to the opioid epidemic, it kind of went like this, and then exponential. And, back then, I remember pain was the 5th vital sign, right? 5th vital sign. God forbid that a patient has pain. And
you saw
you're
in the
denying.
hospital, on every room in the hospital, pain is your 5th vital sign.
And God forbid that you deny a patient a life-saving OxyContin medication.
Life-saving OxyContin.
Right? God forbid that happens, right? And at that time, I vividly remember going to CME dinners sponsored by Purdue Pharmaceuticals and getting this 3% number, right? Yes, there are some patients who are going to get addicted, but it's only 3%. When in reality, the number was closer to 15%.
Wow.
Mm-hmm.
And that's when it got in trouble. Now, you talk about Suboxone and buprenorphine, right? Buprenorphine, it's the actual molecule. Naloxone, it's kind of a safety mechanism in case a patient decides to snort it or inject it, right? And you take that medication and you put it in a pain patch, right? Pain patch named Butrans. Do you know the maker of Butrans?
I don't.
Purdue Pharmaceuticals.
Was it Purdue? I prescribed a lot of Butrans patches.
Purdue Pharmaceuticals, right?
I thought those were quite effective too.
They are quite effective, right? And in post-acute care, we love Butrans
but
patches.
buprenorphine's an agonist-antagonist. So I always felt it was much safer.
It's a partial agonist, right? On that. But you think about Purdue Pharmaceuticals, they said, you know what? We're losing terrain on the OxyContin. Let's take buprenorphine. At that time, let's put it in a patch, make it only indicated for pain, and let's keep this going, right? And when you think about, you look at the pamphlet from Butrans as a patch, which medication they recommended for us to use as a bridge when you change a patient from hydrocodone to Butrans. Remember the name?
I don't.
OxyContin.
I was going to say it's got to be OxyContin.
That's the only one answer.
OxyContin, right?
That's the only one answer.
So I mean, it's evil, right? It's evil. And when you think about and you put that into context on, the opioid epidemic, what's happening, you guys are right. The border, what you said about education. I think that the cartels they tweak the recipe on the fentanyl side to make it a little bit less deadly, just because we're losing so many souls, right?
Yeah.
That it's making an impact. Narcan, education, everything is helping.
But fentanyl can be productive.
Oh no, fentanyl's a very effective drug when utilized correctly by a physician in a metered dose, right?
Yeah.
I mean, if you give a correct amount.
Well, I had to clarify that. What kind of fentanyl you're talking about?
Well, are you saying like sufentanil versus fentanyl?
Well, there's different type of fentanyls, and we love fentanyl patches, right? We use it on palliative care, chronic pain management, and it's very safe when you use it for the right patient, right? Patients who are opioid tolerant, that severe pain, fine, right? But you take something like carfentanil, right, which typically was manufactured in Mexico or Guatemala, and they bring it in. And you have a molecule that it's 10 times as potent as fentanyl, right? So fentanyl, one of the things back when I was doing addiction medicine outpatient, right? I will get a new consult, and I would love to just sit with the patient, right? Just like you took the Monjaro back then. I will ask the patient, hey, how much are the hydrocodones right now? And they're $1 a milligram. Okay. How much is a fentanyl patch? Oh, they're $25. How much are the oxys, right? $1 a milligram. And fentanyl was so abundant that you can get what is called an oxy blue. Basically, they will take, powder. They put a little bit of benzos. They will put a touch of fentanyl, make it into a oxy tablet, and they sell it as an oxy blue for $2.
Wow.
Right? So
that had to have killed a lot of people.
It did.
Had to.
It did. And, a lot of times we talk about opioid overdoses, right? That switch. Back in 2022, that switched to opioid murder because a lot of the unintentional overdoses were kids who, they were opioid naive. They just found a pill, they took it, and they dropped dead.
Terrible. Yeah. I'm glad to hear we're on the right track. It seems like those numbers are decreasing.
It's decreasing. It's working. Whatever it is that it's happening.
I want to go ahead and thank the cartels for decreasing the
thank you very much to Sinaloa cartel and El Chapo.
Thank you, Chapo,
for doing that. But you think about you think about how evil it is, right? Yeah. That the primary substrate to make fentanyl gets shipped to Guatemala, gets shipped to South America. Then they bring it to the cartel. And you think about heroin. Heroin, it's hard to make, right? Heroin, you need poppy seeds, you need poppy, you need to extract it. It's a very hard process and time-consuming. And when you look at the graphs of heroin consumption keeps going down, right? Just because we have so much fentanyl available.
Yeah, the synthetics.
It's much easier to be transported, right? It's smaller. Yeah. And I think that we're doing a better job controlling that.
Mm-hmm. Can I bring you back to post-acute care addiction specifically? Because one of the things, I've heard it before lots of times over the years, but when you and I chatted before the show, you do manage addiction inside some of these long-term care facilities.
We do that for our partners. It's you'll be surprised.
Yeah.
You'll be surprised what we see. And, there's a phenomenon if you look for it, you'll find it.
Sure.
Yeah.
And a lot of facilities, the primary team may not do a good job about ordering drug testing as often as they should. And you will find that, grandpa, it's maybe smoking pot.
Yeah.
Right? Prior to having a hip fracture, right? And they fail. Or there may be cocaine use in the facility.
Mm-hmm.
Or they may use some meth, right? Inside of the facility. And that's something that it's a problem. It's there. It's never going to disappear.
How are they getting this inside the facility? So, just
Very simple.
I'll back up and give my.
It's as simple as having a DoorDash delivery.
Yeah, it's incredible. And on our experience of, when I was in orthopedics and then interventional pain, I saw dozens of 80 and even some 90-year-olds that would do cocaine and meth and admit to it. When you meet a nice female and they're dressed in like your grandma, they're not wearing crazy clothes. They look like your grandma, but they smoke meth. I mean, that happened more often than I could think. But I did not expect to hear that in the nursing home.
Yes.
I thought at that point, and this is more outpatient.
It's there. Let me give you an example, right? Texas, last year, there was a massive battle between the lieutenant governor and your governor, right, in regards to THC.
Yep.
Right? And Texas, it's
Talking about the loophole with kind of Delta 8, Delta 9.
This is between
We'll talk
Abbott
about that.
and,
Yeah.
this is between Abbott and Dan Patrick.
That's right, between them, right? And you think about the deltas, right? Let's talk about the deltas. Yeah. So Delta, it's basically CBD,
Sure.
right?
It's
CBD is legal.
hemp-based, right?
Huh?
Is it hemp-based?
Hemp-based, right?
Yeah.
And hemp, it's cultivated in Texas, 0.03% THC. That's the level that we typically look for. But, technically in Texas, we have the Compassionate Act, which allows patients to take 1% THC product for multiple conditions, right? Prior to last year, I think we had about 10 conditions. Alzheimer's.
Is this like a Marinol?
Marinol is different, right? Marinol, it's actually a cancer medication. We use it for nausea, but we use it for appetite stimulation, but it's different. And you think about those conditions. We used to have 10 conditions, Alzheimer's, ALS, Parkinson, but since last year they added like 130 different diagnoses, right?
For medicinal.
For medicinal
You say
THC,
135?
1%.
Oh, wow.
So it's called the Texas Compassionate Act, right? So that's there. Now I want to take you to the deltas, right? And the Delta 8, which is technically legal, and then Delta 9, which is highly legal. So
Highly illegal?
illegal, right? Very illegal.
Schedule
Delta
1
Which
with
one's
the federal
which
government.
one's the one you would get off the street? Is that Delta 9 or is that neither?
8.
That's 8.
8. That's the one that you go to the smoke shop, the gas station, and you get your pen there. And it's CBD, right? It's CBD that it's heated at a specific temperature. They add an acid to it. So they're now going to make it psychoactive, right? And I cannot tell you the amount of times that I'm at a facility and we have Mr. Smith who likes to go to the gas station to buy their C4 or their cigarettes. And when they come back, they're out of their mind, right? And you think they're having a stroke because they're that bad. And a lot of times it's Delta, right? Delta 8 or Delta 9. So it's a battle.
So the fight was between Abbott and Lieutenant. What happened there?
So in that fight, they're fighting.
Were they fighting over Delta?
They're fighting over Delta. That's one of the primary things. But they're fighting also over THC.
Okay.
Right? And I think they're in a kind of a standoff of Abbott saying, we don't want anything.
Nothing.
Right? Nothing. We're going to be pure. God forbid that this is available for patients or people. And Abbott, he's trying to find more of a balance, right? Of allowing the expansion of the Texas Compassionate Act.
Hold on. Abbott saying you're clean?
Dan Patrick
there you go.
said.
Dan Patrick said. And Abbott saying, let's add them, let's have it here. Let's try to find a happy way with it.
Is there a benefit of any of that inside long-term care? I feel like it's got to be coming, or is it?
I don't know, right? I don't know. When you think about long-term care, you talk about dronabinol, right? It's a very common medication that we use for weight loss. Very effective. There may be a pain benefit through it, and we use it liberally, right? Especially on patients who have cancer or on palliative care. I don't know that there's a benefit on the THC side yet, right? I have to be careful because I am a member of ASAM, American Society of Addiction Medicine. And our view in ASAM, a few years ago, we were completely against it, right?
Against THC.
Against THC. Okay. Now, we're more open. We want THC to be classified as a Schedule 3 medication, just like tynobicodine, just like tramadol, which will allow to have more studies in regards to that.
Yeah. Really, more studies. That's what's needed?
I would
think we have a lot of studies with THC by now.
I think it will allow different patients to qualify from it. A lot of the studies that you have are based on primarily neurological disorders. Mm-hmm. You have some studies in regards to primarily seizure disorder.
We've seen the empirical evidence. I was prescribing Marinol for end-stage cancer 20 years ago.
Right.
And empirically, I did it maybe for weight loss, but in reality, the patients were much more comfortable. The pain levels were down. I used less narcotics. They had less constipation as a result of that. There's lots of benefits of
this. But you prescribe it primarily for nausea, right? That's a primarily indication at that time. Here, we're claiming that it's going to transform pain care. Yeah. It's going to help dramatically. And the data, it's still missing. Right, to make that claim. So I have to be very responsible about.
Interesting.
What I say.
So my background, primarily from a lab sales standpoint, comes from toxicology, and so I was doing toxicology back in 2010, 11 times when, from a primary care standpoint, toxicology, as it relates to addiction or opioid abuse, was new for sure. Mm-hmm. And we did a lot of educating, and a lot of times we would have conversations along the lines of if you just do a subset of patients, call it 10 or 15, 20, that are prescribed opiates chronically, meaning more than three refills, you'll make your own decision if you should utilize toxicology after that. I don't need to sell it to you. You will decide based upon what you find. And it's guaranteed you're going to find some surprising stuff.
So you have to look for it, right?
Yeah.
And back then in 2010, I used to be an MRO, a medical review officer. Yep. So I did do a lot of drug testing, and there are benefits from drug testing, right? Sure. There's no question about it. And I think on the primary care side, poor primary care, right? They get to get the brunt of healthcare. Yeah. And they're dealing with 50 different things, right? Yeah. Now we're going to throw, drug testing to them. So there will be some rejection, right? There will in regards to that, but pain management, there's no excuse, right? In pain management, you had to do drug testing. It's required by the Texas Medical Board. Texas Medical Board typically will say as needed, right? Yeah. How often do you have to do it? There's no answer, right? They want to keep that open.
Sure.
But feels like OBGYN, right?
Yeah.
Where potential use on the mother side can affect the fetus.
Absolutely.
Right? Those are also fields that are required, just like fields like psychiatry.
Sure.
Where, if they're prescribing, Ritalin, they're prescribing different medications, it's definitely needed.
So I guess the follow-up to that was how do you, when you interface with providers specifically in long-term care, how do people think about, if you're in a long-term care setting, you may be there for 6 months, you may be there for 3 years. How do they think about addiction, and do they even consider toxicology? Because we don't do a lot of toxicology for long-term care facilities.
I think it's in long-term care, right? It's been underused. Uh-huh. I think there's a need to have a little bit more surveillance, especially on the skill side. Yeah.
You mean on the long-term side?
On the skill side, right? Especially newer patients that come to the facility.
Okay. Interesting.
Because, if grandpa is there, he's 89, he's using a little bit of CBD or THC, he has a terminal diagnosis, then we had to go into what I call compassionate compliant care, right? Mm-hmm. That's our guarantee. How are we going to help grandma by taking them off whatever thing they're taking. Right?
Yeah. Was that almost like that? Almost is a call not to test.
Correct, right? And I remember back in 2010, there were a lot of physicians who chose not to test for THC just because it was very, very prevalent, right? Yeah. So I
the
think
ramifications of documenting that in your chart when it's Schedule 1 nationally. I mean,
there's ramifications, but there's also the fact that if you do take them off their THC, then you're likely going to increase their opioids. Yeah. So you sit there and go, is that really the best thing for my patient?
It's a hard choice, right? It's a hard choice. So we take every case individually, right? We apply the compassionate compliant care rule. That's our filter for care, and we try to do what's best for them, right? In regards to that. But there's no question that because there's so much complex medical need going to skilled nursing facilities, right? That urine drug testing should play a bigger part in regards to that, just like it is in outpatient. Mm-hmm. And when you think about post-acute care, right? Post-acute care in the eyes of the DEA, whether it's skilled, outpatient, assisted living, it's the same. You are the same rules of doing drug testing when needed, getting pain contracts, and making sure that you're offering multimodal pain services, right? Yeah. Injections, different therapeutics, consults, EMGs, and so forth.
And I understand from a, black and white on the paper, it's the same. But do you in practice, and this is a question I don't know the answer to, in practice, is it really the same? Or would you say that the DEA and the regulators and the Texas Medical Board, et cetera, do they look at a person in a nursing home who's under nursing care that has oversight? Do they actually look at it as the same as an outpatient clinic, or do you really believe it's treated similar?
That's obviously a great question, right? And I have a great answer, I think. And one of the things that we did as a practice and as a group, right, we're growing, we're adding providers, we're adding facility, is that we decided to get a DEA consultant, right? So we hire a DEA consultant. She is a agent, used to be a DEA agent. She formed a company called Guideposts. Shout out to Guideposts. And I asked the same question, right, in regards to that. What happens with a patient who takes methadone? They're taking 80 milligrams once a day. They go to the methadone clinic. They get takeouts, right, for a week. And they end up in the nursing home. What do I do now, right? They have a hip fracture. They have a new thing. And, she basically told me, listen, document what's happening, do what's best for the patient. And, you can tell that there's a different, almost gray zone type of situation when we talk about post-acute care versus the office.
That's what I would think.
Yeah. Right.
I mean, that checks out.
There's a little bit more leeway as long as you're, number one, you're documenting, right? What is it that you're trying to do? I go back to compassionate compliant care, right? And if I stay with compassionate compliant care, then I'm safe. Yeah. And my team is safe.
Do skilled nursing facilities need to drug test more?
Yes.
Why?
Because the need is there. The need for testing is there. There is abuse in nursing homes in regards to drug abuse. Yeah. We're not testing enough, thus we're not seeing it. But I guarantee you that if you take random sample of patients, you will find a lot of drug abuse.
Interesting.
One of the things that I do with our company, right? We are a core value company, right? We have 6 very specific core values. First one is health first, right? There's another core value that it's accountability. And the facilities that we cover, we want to make sure that we have an alignment in regards to core values. And there have been occasions where we left facilities because we felt unsafe in regards to what was happening there. Yeah. Not about drug testing, or whenever we need drug testing, there was no accountability on that side. Mm-hmm. So that's something that it's ongoing.
Well, there's probably a tension there, right? So if you drug test a patient, what is the responsibility of the facility if they're drug testing a patient and that patient continues to have negative outcomes? and the test, essentially positive test, negative outcome, what is their responsibility in moving next? So they're not supposed to discharge the patient, I assume.
It depends on the policies or procedures of the facility. Each of the facilities, even though they may be under the same parent company, right? Sure. Whether it's Ensign, Kentex, or OPCO, or Creative Solution, it depends on policy and procedures. What I've seen in a lot of facilities that if there's an abnormal drug test, let's say there's ongoing use of meth, right? From my standpoint as a provider, is this addiction, right? What can I do as a provider to treat the patient? Can I treat in-house, right? We talk about how medical need is increasing in long-term care. Long-term care facilities have access to psychologists. They have access to drug tests. They have access to counselors, right? So to a degree, that patient can be treated on site if there's no harm to the patient is non-suicidal, and there's no disposition, right? Now, you get into a situation where patient is doing meth, the sheets caught fire because they were smoking meth at the facility, and they almost burned out the whole thing.
This hasn't happened to you, has it?
I'm making that up. Right? The sheet caught fire.
I've seen some stuff too
because they're smoking meth, and now you're putting the life of every single patient at the facility in danger.
Yeah.
Right? Yeah. So what I've seen is that a lot of facilities have a 30-day policy where they get the patient a notice of 30 days and then they move on.
I feel like as an administrator, I wanted to know. I've had many experiences like that, but I wanted to know what was going on so that I could interact, or I could put things into place where, hey, this might be a situation, but just trying to be more proactive as an administrator, I think that's super important.
Well, you go back to, addiction has always been fairly complicated just because we never had clear guidelines in regards to disposition, right? So ASAM, the American Society of Addiction Medicine, they did something about it. They said, you know what? Let's create the ASAM guidelines, right? We're going to create guidelines where, if you have a problem with meth, it's different problem with heroin, problem with cocaine, and different circumstances. So are you going to go outpatient, right? We call that level 0.5 versus are you going to go to a hospital, ICU, we call that level 4, right? Which is the massive level of care, typically for patients who suffer alcoholism. They're going through DTs, and they're going to die if you don't treat them. Where is post-acute, right? Post-acute, if you think about it, there's a potential level in ASAM. We call it level 3.1 to 3.3, where you have a patient that has a medical need, right? They just broke a hip. They have a compression fracture. There's something, they just had pneumonia. They had potential endocarditis just because they were injecting drugs. And they have a skill need. So where do they go?
Wow. Right? Sure.
And post-acute care, in my opinion, is a perfect level for that patient to go to.
Interesting.
Which is level 3.3 to 3.1. So that patient is not going to go to a residential inpatient care because they're lacking the medical care. Right. They're not going to get the IVs. They're not going to get that care. So that's another example of how post-acute care is getting more medical need. Yeah. And they're trying to do their best to keep up with it.
So kind of tying it all back together, talking about GLP-1s, talking about addiction. Can GLP-1s be effective in fighting addiction?
The answer is that I don't have an answer.
Nice.
Right? That's my best answer. However, I can take you back to
Sounds like
when
a
I was
politician.
doing. I'm just saying. I have to be careful here, right? I remember outpatient, right, practicing obesity medicine, and I also had an addiction clinic. And I remember a large subset of patients telling me, listen, doc, I lost 5 pounds last month, and I no longer drink like I used to.
Wow.
Right? Like that thirst, that noise of drinking went away. Just like in addiction, we talk about food noise.
Sure.
Right? There's also that addiction noise in regards to alcohol and drugs. So I want to go back to DSM-5, right? I think you mentioned something about it's obesity and addiction.
Mm-hmm.
And based on DSM-5, the answer is no.
Okay.
Right? But
can you describe what DSM-5 for those that don't know?
Diagnostic Statistical Manual, right? That's what psychiatrists use to determine, okay, you have criteria for depression, you have criteria for bipolar, you have criteria for something else, right? And when you think about that, currently, as we sit today, there's no such thing as addiction to food based on that.
Wow.
Now, when you think about addiction, right? All addictions have something in common, right? It's a disorder of pleasure, right? There's always unintended consequences. There's harm to themselves, family members, society, and you cannot stop. Now, you take a patient who has class 3 obesity. Let's say they weigh 350 pounds and they go to a facility. And now you're going to put them on a 1800 diabetic double protein diet, right? Typically what I see is that, one, they're eating their diet, but they're not losing weight. How is that possible, right? Because I mentioned DoorDash. There's a lot of food delivery that happen at facilities, right? Yes. And when you think about that patient, not only they go through withdrawals, they're harming themselves. Yeah. They're harming their relationships. They cannot work. They cannot stop. And they meet every single criteria for addiction. Yet DSM-5 says that that's not a addiction.
So
Why
if you were the architect and the author of DSM-5, would you classify obesity as an addiction?
Absolutely. Absolutely, right? And you question, why is that not happening? What forces are behind this that are keeping that from happening? And I don't know what that is, right? But without a doubt, right? Food addiction is real. Yeah. It happens. There are real consequences to it. And we will see in the future that GLP-1 will play a bigger role in regard to managing that, right? We're never going to cure addiction. You know, addiction is multifactorial, and there are multiple factors associated with it, but GLP-1s are going to be a game changer for it.
I would assume that you find your purpose in helping people and talking about addiction and talking about pain management. Walk me down that road.
You know, you think about purpose, and, you know, years ago, through a coaching program, I learned about the 4 freedoms, right? The freedom of time, money, relationship, and purpose. You know, now in my career, I don't trade time and money, right? Time is too important, right, in regards to money. But post-acute care, lecturing on addiction, talking about pain, managing those patients, helping parent companies, making sure that they get a better outcome, it really fulfills a purpose and relationship standpoint. Yeah. Right? Last year, I had the opportunity to not only work with the great people at Texadona. I don't know if you guys know about it.
Sure.
Right.
Was there?
Shout out to my guys over there at Texadona.
Julianne is
Julianne.
Will you ask her to come on the podcast? Julianne, I've asked you to come on the podcast. You have to come.
She will. She may be too busy.
I love her to death. She's fantastic. So I'm going to use this to get you. You're next on it.
She never stops, right? She never stops.
I love her. She's wonderful.
And she's 100% purpose and relationship. So I was blessed enough to be able to give a lecture to the chapter, the DON on pain, right? Just for the facility. Last year, I was able to go to the Texas Geriatric Society, so I gave a lecture on pain and addiction. PLTC, right? AMDA. Do you know guys about AMDA? AMDA was instrumental for me, right? Years ago, I learned about AMDA, and I like it so much that I became a certified medical director through them. Just because I wanted to learn about PDPM, I wanted to learn about MDS, I wanted to learn about challenges at facilities. And if I'm able to help that facility from any other standpoint or help my medical director, then I stay busy, right? So last year was really busy for me in regards to that, right? Not only that, I was able to give a lecture at my peeps at UPCO. They had a regional dietitian meeting with Cherry McCaskey, and I got invited to give a lecture. So I gave a lecture on GLP-1s and post-acute care. So really busy with that. So I really enjoy that. Obviously, time with family, time with my wife, my kids, soccer. I love that. But, in regards to purpose, I'm at a point in my career that from a physiatry standpoint, I did everything.
Yeah.
Right? Outpatient, inpatient, EMGs, interventional pain. But once I found post-acute care, which came during a really tough time coming from a prior practice, it really allowed me to develop a unique ability in regard to our services and what we do for post-acute care.
It's awesome.
Yeah,
That's amazing.
Through tough times comes the rainbow.
Right.
Comes really good stuff.
Right. And you think about, something as simple as, there's a concept called gap and gain, right? Where, if you are always thinking about, okay, I'm not reaching there, I'm not going fast enough.
Yeah.
You're really in a bad mood, right? You talk about, it's not happening. What do I need to happen? How come not happen? Rather than, going through the process of it and enjoying the journey, right?
Mm-hmm. Yeah.
Living the experience, meeting people through Texas Donut, meeting people at Texas Geriatric Society, and, just the ability to work with multiple parent companies, right? UPCO, Kentex, Creators, everyone. I really enjoy that. That's my purpose.
That's awesome.
Well, you've been instrumental in changing the landscape of long-term care, and so we thank you for sharing your insight with us. We thank you for sharing your wisdom. We've talked for a good amount of time, and we could talk for a lot longer. We'd love to have you back on. You are a wealth of knowledge.
Love to be here.
Yeah.
Love to be back.
Thank you so much for joining us.
Thank you.
Really
It's
appreciate
great
it.
speaking with you. Thanks so much.
Likewise.
That was awesome. Thank you, Dr. Vargas.
right.
Ladies and gentlemen, this is Dr. Vargas. That was really good. I enjoyed that conversation a whole lot. Thank you for sharing. Thank you for your purpose. Thank you for changing long-term care. Thank you for being who you are and what you do.
I think when you think about what you guys do in regards to elevating care and how you're collaborating competitors, right? Are you having to level to the same care? I'm hoping to do the same with on my side, right? We want to make sure that patients get good care, get great outcomes, and that they do well, right? That's what we want to do.
That's what it's all about.
For sure.
Yep. Changing lives, improving patient outcomes and experiences. That's what it's all about.
Yes.
Right.
Ladies and gentlemen, thanks for listening to Our Purpose Podcast. We'll see you next time.
Thanks. Awesome.